Good evening, everyone. Welcome to tonight's Lung Cancer Living Room. Welcome, everybody in the room. Those of you who may be joining online via YouTube live stream, and those of you who may be joining through the Facebook stream, welcome, welcome, welcome. We're happy to have you all here tonight. Lots of veteran faces and some new faces. It's good to see you all. Thank you, thank you, thank you. As you guys know, one of the things I want to start with is thank you for coming a little early tonight. I know we kind of changed up the flyer to say dinner at 5 so that people wouldn't come in right at 5:30 and try to eat, and making people wait online all night while everybody grabbed their food. So I appreciate those of you who picked up on that. Oh, you didn't, Joanne?
I didn't see it.
All right, well, anyway, thanks for accidentally showing up early. We appreciate it. It's hard with the people online who are there at 5:30 waiting for, you know, something to broadcast instead of just looking at a blank screen. So we're trying to change that up a little bit. So thank you, thank you. As you all know and have anticipated, Dr. David Gandara is here with us tonight from UC Davis Cancer Center. He is also a veteran at the Living Room, so we're very, very happy to have him come back and talk a little bit about. We've talked a lot about immunotherapy, what it kind of has meant or what it's looked like since some of the earlier approvals. But now what we're going to talk about is making sense of it, because I think there's a lot of confusion for patients and some physicians alike out there about what exactly is immunotherapy, when's an appropriate time to use it, and how to use it on who. So we're really, really, really excited to talk with Dr. Gandara about that tonight. We are going to start with the Around the Room as usual. Anybody online, whether it's on Facebook or signing in through YouTube, Michelle is monitoring the live stream on YouTube. And I think David Leduc is monitoring the Facebook Live. So as you have questions, Michelle is all ready to ask them for you. So please, please, please send them in. And or if you want to introduce yourself, please do that too as we're going around the room. Barb and Dave always sit to my left, so I'm going to start with you guys, if you don't mind, to do introductions.
It's like Sunday dinner. People find a seat the first time they come, and then they're glued to that seat.
Who moved my cheese?
Yeah, right.
All right. So I was diagnosed in March of 2017, and I was EGFR positive. So I got put on Tarceva. And also had some mets in my brain, so I had radiation for that, stereotactic, and also had one lymph node that had some cancer cells in it, besides the lung tumor. That lymph node, the Tarceva has been working marvelously, but the lymph node over the last couple of scans has been showing activity. So they did a blood biopsy, then they did a tissue biopsy. They saw no genetic changes, and so no T790 was showing up. So then they went in, after the tissue biopsy, they ordered a PET scan, which we just got the results back a couple weeks ago. And now the plan is I'm going to go for the stereotactic body radiation therapy. So I'm going to go in Friday for the markers, and they'll be putting those in. And then on Tuesday next week, I go in for the body mold, and then I'll do 5 days of the radiation. So that's where I'm at in my journey. Barb's got additional.
I'd just like to say that Dave's lymph node is in the no-fly zone, because I think that's a really cool terminology.
Right.
But actually, it used to be the no-fly zone, and now it's amazing because they are actually able to go in and do this very targeted radiation therapy, so that's pretty cool. I always say I'm not his caregiver because I don't really take care of him. He's still responsible for his own laundry, et cetera. But I am his communications manager, and more recently, I am the Edith head of the upcoming lung cancer walk, because I've been working on costumes for our team for weeks now, and I still have hours of sewing ahead of me, so that's what I'm here for.
Excellent.
And I understand my Enzo also has his own costume. So, yeah, that's my dog.
This is true. Esty, do you want to grab your mic? You don't have to. You absolutely don't have to if you want to pass.
I don't remember all my days.
All my days.
All the days when I had done one.
Are you want to pass, Esty? Okay, she wants to pass.
Okay. She just came to see Dr. Gandara.
Hi, I'm Rick. I was diagnosed with stage 4 adenocarcinoma back in February of 2015. I didn't have any of the genetic mutations, so I went through straight chemo, started with carboplatin and Alimta, and then Alimta only. And then with Alimta only, my adrenal gland stopped responding, so they did some surgery and removed that. And after that, I was on Taxotere for a few months. But in February of 2016, my PET scans came back fully clear and clean. So I've been no evidence of disease since for 2.5 years now. So.
Yay.
And Rick's been coming for a long time to the living room, so.
Yeah.
Yeah.
That's good news.
Mr. McCarter's a no. Tina?
Tina.
He said no.
He said no. My name is Tina, and I've been coming here a long time, fortunately. I was diagnosed in 2010, EGFR positive, and I did take Tarceva for a short time, and then another doctor decided to do radiation and chemotherapy, standard treatment. And after that, my doctor decided he said, let's just do the Tarceva since we know it works for you. Let's just do it for a year for kind of insurance after my treatment. And so every year I've been evaluated, and he says, well, it just seems to be working, so let's just stick with it. So I have stuck with it now I've 7 years on Tarceva, and so far so good. Clean scans. So I'm very blessed and grateful.
Tina, do you want to just mention too, are you still in that study?
Not really.
Oh, never mind.
I mean, they took my
Pass the
blood,
mic.
and then
Yeah.
I didn't really
You don't have
find
to go back
anything
for
out
serial
about it.
blood draws or anything.
No, they didn't take another blood draw last time, so
Okay.
they said
never mind.
they don't want my blood anymore. I think it would be very valuable myself.
Right.
Maybe it's boring.
Oh,
Yeah.
right.
Actually,
Yeah.
that's good.
That's good.
Boring,
news.
boring blood is a good thing.
Share?
Yeah, hi. My name is Edward. I was first diagnosed last May of 2017. And I had a 7.5 centimeter tumor on the left and a 2.0 centimeter on the right. And the first thing they did to me was the radiation for 6 months daily for 20 minutes, Monday to Friday. And I had chemo, combo, carbo, and Taxol once a week for 5 weeks, low dose. And the last one was a full dose, which I cannot tolerate, and I said, that's it. The treatment started August, and it ended September until 3 months later, they had the usual PET scan, MRI, CT scan. Everything was perfect. All was left with the 7.5 tumor was a scar, period. It just disappeared. I was surprised when I heard from the doctor told me that, hey, it's gone. Wow. I had the SBRT on a small one for a couple hours, I believe was that, and it was also gone in a couple hours. I go to Stanford, and that was, my treatment ended September. Yeah, it ended September, and March, 3 months later, another, combination of PET scan, CAT scan, and MRI. Everything was just perfect until the doctor noticed that I had fluid in the lungs. So it was quite minimal. It's not something to be alarmed of. He said that you have fluid in the lung. And we wanted to test it and see if you have anything in the fluid. And they did the torosynthesis. They pulled several liters of fluid, and they found out that I had cancer cells in the lungs. And last July, they took a PET scan again, and the fluid had increased twice as much. And they decided to put me into immuno for Keytruda, because I was PD-L1 50%. So thank God it wasn't 49. Right on the border. I said, wow, that was close. You know, the anxiety and all that alone, having this is more than beyond my imagination. And what more about the PD? I said, wow, Doc, come on, let's give us a break here. So yesterday we were at the hospital, met with my oncologist, and she asked me, so Edward, when do you think, would you be ready to do the treatment? I said, well, I just want to breathe a little for a while, maybe give me a week or so. He said, well, bear in mind, it's not, in your case, it's not really an emergency. So you're okay for a couple of weeks or a month from now, because the tumor is really so small at this point, it's like the eye of a needle on both sides. And he said there's really no cause of alarm.
The noodles.
Yeah, but the nodules. But he said if you wanted us to start early, then we'll know early if it works for you or not. Then we'll have the chance to try other drugs. You know. And I said, well, that might be a good idea, but I still need to talk it over with my family. That was just yesterday. And she said, fine. Just call me when you're ready. So Friday, we're going back for the clinical studies. I said, hey, see if I'm qualified, and I'm willing to go for it. And today I'm here, been talking to Kim, and I always forget her name. Michelle. And Michelle insisted way back to show up in the meeting, and that's why I'm here today.
Oh, that's a good girl, Michelle.
Michelle's over here.
Where is she? Good girl.
So yeah, Michelle and Kim both.
Show up.
Yeah,
Just show up.
Just show up. It can be intimidating, but once you're here, it's like, tell the people that are watching online, it's not so bad once you're here, right? It's nice to be in this environment with other people who are walking your walk, right?
And Dr. Gandara is you'll be able to ask him some questions later about immunotherapy, because that's going to be, a lot of what he talks about tonight.
Yeah.
I just want to add that they found noodles on both sides of the lung.
I love that.
A few on the fissure of the lung, and also on the right. And they all were increasing in size in 2 months. It did increase. One was 7 millimeters, and it increased to 14. So it like doubled in 2 months.
Those are all good reasons to get going.
Yeah. So that's why the doctor says, well, let's not wait.
Thanks, guys.
Okay, I'm Joanne, and some things have happened since the last living room, so let's see if I can get it straight. But backing up, I was diagnosed in September 2016, 2 years ago, with stage 4 adenocarcinoma, EGFR exon 19. And I always make a point of saying that I was under doctor's care for a year prior to that, misdiagnosed with everything from allergies to acid reflux, before somebody finally did a chest x-ray and discovered that I had by then, 7-centimeter tumor. Was put on Tarceva, which shrunk the tumor to 2.5 within a couple of months. and did fine on Tarceva for 23 months. And then I mentioned last time that I was participating in a trial at Natera for blood biopsy, and I was going to have the results that was a Tuesday. I was going to get the results on Thursday, and it did show an increase between two blood tests, in the interim of two blood tests, of tumor cell DNA. So, and I had been on a reduced dose of Tarceva, so whether it was that or whatever, of course, we didn't know. Dr. Blakely, well, my oncologist looked at the results of the blood biopsy, and yes, there was definitely an increase, but we don't know what it is. And she mentioned that I don't think she said we needed, but I probably said, well, how do we know what it is? And she said tissue biopsy. I fortunately, as I look back, had an appointment already scheduled with Dr. Blakely the following week. I see him every few months. And he immediately said, we need a new Guardant test. We did the Guardant test. I got the results in under a week, and there was T790. So I was immediately changed to Tagrisso, and that's where I've been the last month, and I'm hoping that that goes on for years and years. But that's
Feeling good? Feeling good?
I know you've had some real issues with the symptoms, the side effects from the Tarceva. Are they less on the Tagrisso?
So far, no rashing, or I had the scabs on the head thing. If I can say it politely, so far more diarrhea, but I don't know long term if that's going to even out or what. Mm-hmm. But otherwise, there was no evidence to me in terms of energy or anything that I'd even changed medications.
Great.
So that's where I am.
Good for you.
Thanks for the update.
Thank
John.
you.
Yeah, I bring my superhero coffee in the morning.
Oh, that's a big round of applause for that. Yeah. We have to take care of our superheroes, right? Tony, hello.
Yeah, he's like, what? No.
Coffee, morning. He's not even looking over here.
Hi, my name's Robert. I was diagnosed with stage 4 back May of 2014. I've had generic chemo and radiation and such as that, and as of now, I'm doing great.
He's our superhero.
Okay.
Yeah. He's swaying too.
My name is Amy, and I'm a supporter of the foundation and a patient advocate.
My name is Brett, and I'm the same.
My name is Nikki, and I'm exactly the same.
Hi, my name's Wayne. My wife's over there getting some food.
There she is, getting food.
That's Rebecca. In November of 2017, she was diagnosed with non-small cell lung cancer adenocarcinoma. She was diagnosed stage 3B. We started chemotherapy in January for about 3 months to treat a 4-centimeter tumor. During that time, she had progression of disease. We saw some small, millimeter nodules on the right-hand side, and our biggest surprise recently was that she has some 2-millimeter cysts in her brain, which were thought as benign, but they actually turned into 5 nodules that we had just cyberknifed a couple of weeks ago. So we're hoping that that goes away and there are no new ones. During that time, also, we finally got our foundation results from a VAT surgery to prove that, her disease had progressed, and she turned out to be a KRAS G12D mutant. Sorry. So she's been on chemotherapy for about 5 weeks now. Started with carboplatin and Alimta. And just 2 weeks ago, the doctor added on Avastin. I think he did that so that to give the brain time to heal. We had the pleasure of meeting Dr. Gandara 2 weeks ago up in Davis, and with some luck, we hope to not see him for a long time.
Other than here.
But
Hopefully we're fortunate enough to see him if things continue and we are on the trial.
Yeah, he gave us a lot of information on some exciting new trials targeted to her specific pathology, and a lot of exciting things to come too. And we really learned a lot from him, and we hope to learn a lot from him tonight.
Okay.
You know, I
Thanks,
have to tell
Wayne.
you, I love the fact that you're saying we and us, and, you know, because when one person in the family has cancer, everybody has cancer. So I love that you're speaking in the third person.
He's awesome. I can't even begin to tell you how understanding, empathetic, caring, all my medications. I don't even know what I take sometimes. But he's always getting everything perfectly good. We went to a doctor's appointment this morning, and he's just rattling him off.
Yeah.
You know?
Yeah.
Great at the beach. Good with the kids and the dogs.
That's great.
I won't loan him out, though. His sister's here tonight, who also, not that long ago, gave her kidney to him.
Wow.
Oh,
Very
come on.
nice.
Come on.
Anyway, thank
Wow.
you very much. And
Wow.
what we found out, too, is that I'm stage 4 cancer was supposed to be stage 4 from the very beginning, but they just didn't call it that, which I've been dealing with, just hearing those words and taking them in, and what do they mean to me, you know? Still struggling with that. Anyway, thank you.
Thanks, Rebecca.
Hi, my name's Amanda, and I actually work for Foundation Medicine, and I'm really excited to be here tonight.
We need those tests back in a week, by the way. Can you speed that up? Get the message back home.
I'm Ron. This is my superhero hat.
Perfect.
On my hat, it says that they are dragon warriors because the way you pronounce the word dragon in Chinese is lung, and it's spelled L-U-N-G.
Oh, wow.
So
Very
we want
nice.
you all to be fierce lung warriors.
I love that.
We'll go with that. We'll go with that.
I'm here tonight as a lung cancer advocate. My wife had lung cancer, and she went through 15 different lines of treatment, 3 phase 1 trials with Dr. Gandara and Dr. Reese, and I'm just very grateful for all the work that they're doing there to have kept her alive for as long as they did. My other reason for being here tonight, besides a free dinner, is that Sally can't be here, so she can't defend herself against the fact that I brought the Chinatown Coffee Crunch Cake version.
That's right.
Last week we had the Japanese town version. You guys can do the taste off, and Sally can't vote, so we'll get to see who's better.
Right.
So for those of you who are new, Sally, God love Sally, she's a lung cancer survivor, and she has dedicated herself to bringing dessert. And then Ron and she kind of got into this thing about coffee crunch cake and who and where does the best coffee crunch cake come from. It's all over social media. They're fighting about it.
Exactly.
Yeah, it's right there. Yeah, right?
Yeah.
Like, I mean, they're fighting about it
Right.
on social media. It's everywhere. They're not fighting in the most friendly way ever. But so I
not
can't
so
wait to
friendly.
taste it tonight.
So your superhero gift tonight, what Sal and I talked about, was that as a clinical trial, one must, as a cancer patient, eat cake for breakfast.
I love it.
My name is Peter Van Zitter. I came up here from Los Angeles.
Whoa.
And I came for the dinner.
There you go.
Peter's a great lung cancer advocate, too. He went to D.C., and then he went to the Stand Up for Cancer last week and met Katie.
Oh, fantastic.
Yes.
Yeah.
Did you do the LCA? Were you guys together at the LCA summit? Is that what you were doing in D.C.? No. Never
No,
mind.
this was a different. This was different last week.
Oh,
it was a rally.
Oh,
Yeah.
nice.
No, I came up to attend the meeting, and I wanted to meet Dr. Gandara. I heard so much good things, and I hope to see him someday. I through a TB test that was positive because I was inoculated against TB as a child in Europe. It came out positive, so they automatically do an X-ray, and that's how they found a nodule. And so in 2015, went to have surgery to have it removed, but the surgeon noticed that there was little white specks everywhere and told me that it metastasized. So it was elevated to stage 4. Went on Tarceva, did that for about 15 months. Then was tested for the T790M, and I was negative. And so I went on carbo Alimta, and then Alimta maintenance for 20 months. And then in May, when that failed, I went on to Griso. They tested for the T790M, and it was positive. So I'm very grateful, and I feel very blessed when it comes to the side effects. It's been very, very minimal. I've been very active in running and climbing and hiking. Again, just very, very grateful for that.
Thank you. Yeah.
How long did that drive take you, Peter?
About 5.5 hours.
Okay.
Really?
You're staying the night here,
Right.
here, yeah.
Yes, got an invitation from
Perfect.
Okay, awesome.
I met her and her husband in Washington, D.C.
Oh, that's
Nice.
great. That's
Excellent.
great. That's great.
I'm Maria, and I was diagnosed October 2015. It's gonna be 3 years. I'm been on Tarceva. I had surgery. Then I found out I was stage 4. I had cyberknife in my brain. And I've been on Tarceva since that time. Many side effects, all of them, everywhere, but here. So I'm fine. This is my second time here, and it's nice. The food and the people really nice.
Aw,
Yeah.
thanks, Maria.
Hi, I'm Kathy, and I came last time with my 90-year-old mom, Chris Coons, who was diagnosed in just this summer with non-small cell lung cancer, and that's about all we know so far. We are waiting to see if she's a candidate for the SBRT treatment and at John Muir, and haven't progressed any further than that. We hope to get a biopsy use the biopsy to find out whether she was EGFR or any of those things, and it came back that they didn't have enough tissue. So we're waiting to move forward and make decisions. So I'm here to hear Dr. Gandara and hear what all the options are down the road. Mom's nodule is only 2.5 centimeters, and she's feeling great, so and very energetic.
She is a little superhero.
Yeah, we went off to a wedding in the Columbia River Gorge, and she hiked the last mile of the Pacific Crest Trail.
Yeah.
Cheryl Stray did.
Wow.
I'm going to have trouble getting home.
With the bride and groom, so she's having a good time.
That's awesome.
Good for her.
That's great.
One thing at a time. And
Yep.
we're grateful to be here today. Thanks.
Thanks, Kathy.
Hi, I'm Azita Taylor, and I'm a patient advocate. I'm here to hear Dr. Gandara.
Hi, Nicole Thompson, patient advocate as well.
Daniel Anderson, I partner with the foundation on the patient registry.
Yay.
Hi, my name is Christy Peterson, and my daughter used to come to this meeting.
Oh.
Linda Seltzer, sister.
Hi, my name is Evangeline, and I was diagnosed with NSCLC non-small cell lung cancer, adenocarcinoma 18 months ago. And the doctor, I'm EGFR positive, so my doctor put me on Tarceva May of last year. And after 11 weeks. I had a CAT scan, and it showed that my tumor on my upper left lobe has decreased by 1.2 centimeters. It was originally diagnosed 3.6 centimeters, so it has decreased by 1.2 centimeters. And as of August 7, I had a complete PET scan, and I met with my oncologist August 10, and he said everything's dormant. However, my CyberKnife oncologist has to monitor my head. I'm going to have another MRI in December because the tumor on my right brain, he said, it's almost disappeared now. However, the tumor on my left bone of the skull has increased from 12 millimeters to 17 millimeters. So that's what they're being worried about and going to monitor in December. But so far, by God's grace, I'm here. And this is my second time to attend this living room session. And I was so happy, and because it was very educational for me, and I have something to look forward to go every month.
Aww.
Thank you.
Hi, I'm Nancy Waringa. Grateful to be here. This is also my second time. I was diagnosed in November of 2017 with stage 4 small cell. And I had had it probably for a long time because mine loves my sodium and it creates havoc. And I was in the hospital for 3 months with sodium issues before they could figure out that I had small cell. And the other complication was no one could ever find a main tumor. And so my oncologist, who is here locally, didn't think Stanford would accept me because they couldn't find a main tumor. However, just recently they went back to my original biopsy and found remnants of lung cancer. So then they decided it was lung cancer. So now I have the oncologist here and the oncologist at Stanford, and they're working really well together. I did finish a whole treatment of a carboplatinum and etoposide, and then I went immediately the next day on to immunotherapy and Opdivo, and then that was the only one. But then after 6 treatments of that, my cancer flared right back up, and I was put right back on carbo. And after a few treatments of that, I became really toxic and very ill. So I've been just taken off of that. So now they're trying to figure out what to do with me. So we're getting, the immunotherapy for this, do this, but this will make you really sick and do this. So, remains to be seen what's going to happen. But thank you for being here.
Thanks, Nancy.
Hi, my name is Karen, and I am fortunate to say I'm a 10-year survivor. My tumor, I was fortunate, it was found very early, so I was just a stage 1B, and I went immediately to surgery and had the upper left lobe removed, and then I had treatment of carboplatin and cisplatin, and now I'm trying to support this amazing foundation as much as I possibly can. Thank you.
Thanks, Karen.
Hi, my name is Ran Long. I was diagnosed lung cancer with a squamous cell, stage 3B, back in November 2014. And after that, I went through 3 rounds of traditional chemotherapy. So the tumor got shrunk by 40%, and then the surgeon took me, and I had the whole left lung removed. So ever since, I've been on the every 6 month surveillance check, do the CT scan, and after 2 years, this is my 3rd year, I've been switched to every 1 year do a CT scan. So far so good. As everybody, I want to say I can't appreciate enough to always come here and whatever this living room and all the work that you have been doing for all of us. Thank you.
Anybody? Are we done? We done? Is there anybody online, Michelle, that wants to say anything? Or anybody on Facebook? I don't know where. I think David's filtering all that to you anyway. You have a question for when there's questions? You already have a question. We haven't even started. Excellent. Thank you all for sharing your stories. Those of you, there's a lot of new people in the room tonight, and I'm not sure if you've tuned in remotely. I'm assuming that you have, but what you guys allow us to do here, and I know it can seem a little intimidating with the cameras and the lights and all of this stuff, but what you don't know is happening behind the scenes and with the people that are watching live, and Michelle is talking to online, and David Leduc, our executive director, is talking to on Facebook, is you're bringing this warmth and this environment to them in their own homes. And it's such a huge, important, amazing thing that you guys are doing, sharing yourselves and your stories with other people so that they don't feel so alone in this disease. I'm going to step back and get a somewhat, well, I'm not going to say nostalgic because that was just a terrible word for what I'm about to say, but when this first started, part of it was, came to be because we were talking with patients who felt like they didn't have a place that they belonged, right? That where they could unite and be with other lung cancer patients and really talk and meet with people who were walking the same walk as them. And so it was one of those sort of if we build it, they will come things. And I think you can tell by the people in this room tonight and the couple hundred people who are on the live stream and the couple 100,000 people who between tonight and tomorrow will watch this on Facebook. It's having a huge impact. So thank you for allowing us to share this with them, because it means oh so very much to oh so very many people in 144 different countries. So
145.
Is it 145 now? 145 different countries.
But who's arguing?
But yeah, it's you and I.
Right.
Yeah, that's fine. Do you want to introduce yourself really quick and give? There's some new people in the room. Just give a quick,
okay.
Mom.
Okay. All right.
Quick little history of your story.
I'm Bonnie. I'm a 14-year lung cancer survivor with my friend Karen, and Tina's backing me up, and I want that for everybody. And the whole reason we started this foundation was because there wasn't enough work being done on lung cancer 14 years ago. And I'm sure Dr. Gandara tonight can share a little bit with you about where we were then and where we are now. And birds of a feather flock together, and it is so comforting to all of us to know each other and to share with each other, because everybody leaves the room more hopeful. They come in hopeless and leave hopeful when they hear about all of these people surviving and getting through this terrible disease. So.
And for those of you who don't know, Bonnie's my mom, and so lung cancer entered my life in 2003, late 2003, when she was diagnosed, 3B, and my sister, the younger sister, she's over there, yeah. The younger sister, right. She's back there behind the door, and there's a boy in between. As a family, and Poppy, my dad over here, we all got together and decided that well, we didn't really know. Well, we didn't know anything about, who knows anything about lung cancer if they're diagnosed with lung cancer, which is the sad reality, right? And as a family, we decided we were going to not accept the cards that she was told she was being dealt, and to fight and to have hope. And so I couldn't be more proud of what she has created here and the hope on the wall that we can bring what we chose as a family to all of you. So that's sort of where my journey with lung cancer began. And then I've said in the past, there's going to be a lot of repeats for those of you who were serial watchers and or attenders of this meeting. But historically, I've tried to ask, our speakers for bios, and Dr. Gandara and I've known Dr. Gandara since this foundation started, and I met him very, very, very early on, and he's one of my most favorite people on the planet, other than you, Mom.
On this planet.
Yeah. And we couldn't be happier to have him here tonight, but rather than reading off bios and taking my reading glasses off and on, because yes, she does have a daughter old enough to need reading glasses for a long time now, I feel like it's better for them to tell you who they are and why they chose lung cancer as their area of expertise. Because who can tell your story about why you're here better than you? And then we'll jump into tonight's topic.
Okay. Well, first, it's great to be here again. I don't know if I did the first living room, but
I
it was
think
pretty close to the first.
Yeah.
Which was when?
7, 8, 9 years ago.
10 years ago.
We're gonna fight about that too.
About every year or year and a half. I've seen some of the other presentations that people do in the living room, and as Danielle and Bonnie know, I'm very proud of my ability to communicate with patients. And so a lot of my presentations here have been how to take information that's very complex and distill it down so that patients and their families can understand it. So if you ever come to see me, you'll see that that's also what I try to do with my patients. The stories that we just heard are incredibly inspiring to me. We have patients with adenocarcinoma, a squamous cell, a small cell lung cancer, all of the major types, and there are major advances occurring in all of these types. What brought me to lung cancer is a roundabout story. When I was in medical school, everything that I rotated through, plastic surgery, orthopedics, psychiatry, etc., I basically said, okay, this is what I'm going to do, because I liked everything. When I got into my internship and residency, I saw a major need in cancer. And I also, because that's when the genetics of cancer were first being described, thought that here's an area which over my career is going to be incredibly important, and I wanted to be a part of that. And then lung cancer I got into for the same reason. I started out as a breast cancer researcher. And of course, there were 100,000 people doing breast cancer. There weren't that many people doing lung cancer. And I said, again, lung cancer is an unmet need. It's an area where I can make a contribution. So that's what I did. Now, what brings me here tonight is meeting Bonnie and her family and the entire organization back when it was founded. And I can remember the first meeting we ever had.
I can too.
And
Same.
It was incredible. There is nothing like this organization anywhere. I know the other organizations. It is special. And to me, although there are many great aspects of the Adaria Lung Cancer Foundation, what makes it special is the emphasis and the interaction with patients. And you just don't get that anywhere. This living room is incredibly impressive. The last time I was here, we had somebody with a question from Australia and I don't know, South America. It's unbelievable the reach here. So with that being said, I was asked to talk about immunotherapy. Now, I know a lot of you in the room have not yet had immunotherapy. Maybe you're not a candidate for it, but it is incredibly important in lung cancer. From my perspective, we can also talk about EGFR and other aspects because there are huge things occurring in every one of these areas. We're about to go this Thursday or Friday to Toronto for our World Conference on Lung Cancer from the IASLC, International Association for the Study of Lung Cancer. So every year, all the lung cancer specialists, and it doesn't matter whether you're a surgeon or a medical oncologist or a radiation oncologist, we all get together and talk about the new things. There's a special session there called the Presidential Plenary Session, where the most important new studies are described, and they've never been presented anywhere in the world. So 2 of those in particular are incredibly important for lung cancer in patients such as you. One is several of you either started or had stage 3 disease. This is a study called Pacific. Raise your hand if you've ever heard of Pacific. So only a few people. Pacific takes the treatment that several of you had with chemotherapy and radiation, and gives immunotherapy with a drug called durvalumab afterwards. And I won't be using brand names in general. I'll be talking about the generic name. For some of the drugs, I have to tell you, I'm not even sure what the brand name is. You probably know better than I know.
Yeah.
But anyway, that is an incredibly important study because we've had no advance in stage 3 disease for 20 years, no major advance. And what's going to be presented in Toronto is the overall survival from that. Everybody's been waiting to see what it is. We already know by press release it is positive. So huge. The other study, and I'll be discussing both of these at the meeting, is in small cell lung cancer. And this is the first study to add an immunotherapy. In this case, it's a drug called atezolizumab, together with chemotherapy, the kind that you had with platinum and etoposide, and to show that that's better than chemotherapy by itself. Again, compared to every other area of lung cancer, small cell lung cancer, no advances in over 20 years. So huge, huge things happening. I'll talk a little bit about immunotherapy. So I didn't know, Danielle, if you want to ask me
You want me to ask questions? Well,
or-
you were pulling a Bonnie on me. You guys were jumping all over the place. No, thank you so much for that introduction. Before we jump into the questions, I want to remind everybody here and everyone watching online that this meeting is for you. Please ask questions as we go along. There are no stupid questions. Do not feel like you're taking up a meeting because the question is too personal to you, because you never know who's watching now or who will come back and watch later that your question may be relevant to. So please, 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 I encourage you, just raise your hand, and if you're online, ping Michelle, and she'll ask the questions for you. So I asked, okay.
I just want to add one thing. You know, David's just being very humble, about who he is and what he's done. He's a past president of the International Association for the Study of Lung Cancer.
Most all lung cancer organizations are like out there.
Yeah,
Past or
you know, I mean,
yeah.
so he knows everything about lung cancer. So take advantage of the fact that he's sitting here tonight. And if you have something off topic, don't be afraid to ask him.
I agree.
And Danielle knows I'll always go off topic.
Exactly.
Yes, that's true.
He and I get along
do you see
really
what's
well,
happening?
really
do you see what's
well.
happening?
Yeah.
What I'm
At
flying
heart,
with right now?
I'm a teacher.
Yes,
exactly.
And you're my pupils for tonight.
He is,
Exactly.
he is. And Dr. Gandara, as somebody mentioned, is one of the few physicians / researchers who is able to explain things to patients at a level that they can really understand. So we always feel so fortunate when we have him, and you have him front and center. It's not everybody gets access to Dr. Gandara, and tonight you have it for the next hour and 8 minutes. So make good use of it. With that, I want to give most people, we've done Dr. Gandara living rooms in the past on immunotherapy, so most people have a general understanding.
Yeah, I really haven't done immunotherapy in the way we're going to do it tonight.
Let's do it.
All right.
Let's do it. What is immunotherapy?
Okay. So first, because I have to go off topic, for any of those of you that either been at my living rooms or have looked at the archives, you know that I like to speak to my patients in analogies. I like to compare something that is very complex about lung cancer and its treatment or its diagnosis to something that they know about. So if you were here before, you heard me talk about fingerprints and molecular fingerprints, how everybody's fingerprint is different from everybody else's. That's the genomics of your cancer. I talked about why resistance occurs in cancer, and it's like a key and a lock. And so your doctor unlocks that cancer. He finds the right treatment. But after a year, somebody changes the lock. He has to find a new key. So my analogy for immunotherapy, which I think Bonnie and Danielle have heard, but I don't think you have.
Oh, just not to interrupt you, but she steals it all the time.
Yeah,
Her analogy.
and I take credit for it.
She does. She steals it all. No, you don't. She actually says, Dr. Gandara always says. So,
Exactly.
So does anybody know what it is? What do I compare immunotherapy to? This is the new checkpoint immunotherapy, the PD-L1, PD-1 drugs. Nobody?
I don't think they've
Okay.
heard it.
So my analogy, I think this is very clever, is the stealth bomber. So you know how radar does not detect the stealth bomber? That's what cancer does to your immune system. So this new sort of immunotherapy, again called checkpoint immunotherapy, the drugs I mentioned, durvalumab, tezolizumab, they're examples. Somebody said they were on, I won't say the brand name, but they were on nivolumab. These are all this kind of drugs, and each one is maybe a little bit different, but basically very similar. So what happens with cancer, and the analogy to the stealth bomber, is that cancer cells are smart. Lung cancer cells are particularly smart. As a matter of fact, our prior president of ASCO said we have the stupid cancers and we have the smart cancers. And lung cancer is a smart cancer. That's why it's so difficult to treat. It's smart because it is complex. It has lots of different mutations. EGFR is one that you've described. But it also has an adaptability to make your own immune system not recognize it as foreign. So whether you know it or not, your entire life, your immune system has been recognizing bad things, viruses, bacteria, sometimes foreign bodies. If people know that maybe after an operation, some people get a reaction called a keloid reaction. In other words, your body's immune system reacts to something that is not self. That's why people reject transplants when they have a transplant, unless you suppress the immune system. So in this case, these checkpoints, PD-1, PD-L1, there are now probably 40 of them, enable that cancer to make itself hidden from your immune system, and your activated T cells, the CD8 positive cells that are meant to react to tumor, don't recognize it, so they don't do anything. That allows the cancer to spread, and it allows it to metastasize. We've known for 50 years that occasionally a patient with advanced cancer would go into what's called a spontaneous remission. And we knew it was the immune system, but why the immune system did this in that rare patient was unknown. What we now know is in that particular patient, something changed in the environment, and all of a sudden, the immune system in that patient woke up and said, whoop, here's something bad, I need to go take care of it. These drugs block PD-1, PD-L1. They do not kill cancer cells. In other words, it is your own T cells, your immune system, that's doing it. So it's different from chemotherapy, and it's different from targeted therapy, like the EGFR drugs. And in fact, because this is all of a sudden self-recognition, we don't know how much of these drugs, even now, we don't know how much we have to give, we don't know how long we have to give them. In theory, 2 doses of one of these drugs could activate your immune system, and in an individual patient, it could be activated for the rest of your life. In fact, in the New England Journal this year, there was a very interesting paper with some of you had early stage lung cancer. Instead of taking a patient right to surgery, they gave 2 doses of one of these checkpoint inhibitors, nivolumab. In most of the patients, the cancer didn't change by CT scan, looked exactly the same. But when the tumor was taken out by surgery, in about half the cases, it was gone or almost gone in terms of all the viable cells being killed. 2 doses. So this is unbelievably different from anything we've had. And when I've been interviewed on this, I said, well, Many people call this a tsunami that has hit lung cancer. But I said, no, I'm from California. This is not a tsunami. This is an earthquake. Because a tsunami, you know it's coming, it's here, and then it leaves. The earthquake, by and large, we don't know. All of a sudden, you have an earthquake. And that's how these drugs came onto the scene. In lung cancer, and I'm sorry to keep going, but I'm on a roll.
I want you to keep going. Because I'm going to have a question for you when you're done with this thought, because and this is like somebody else might be thinking it, but I have a question. Go.
Now you made me lose my train of thought. Go ahead, ask your question.
Sorry.
Earthquake.
Tsunami, earthquake.
I used the S word. I didn't mean to on TV. But so my question is, does that go the same for some people on targeted therapies? Like, because there's some people who have been on targeted therapies for 9 bajillion years with NED, and the question is, do you take them off or do you leave them on, right?
It's different.
It is different. Okay, that's my question.
So in theory, for instance, a lot of you have EGFR mutated lung cancers. You need to have the drug to keep the cancer suppressed. In other words, if the drug is stopped and there are still cancer cells that are alive, it will come back. Now, what we don't know, because a lot of your patients in that area of lung cancer foundation, some of them have been on some of these drugs for 15 years, right? Mm-hmm. What we don't know is maybe in that patient, they're already cured. Mm-hmm. In other words, all the cells are dead. You don't know that. Now, these days, and I'll come back to this in a minute, several of you talked about doing blood genomics, like the Garden tests, or now Foundation Medicine has one, et cetera. You can sometimes see if there is residual mutated DNA in the blood. And one of you brought this up in your case. If there is, that means there are still active cancer cells. If there isn't, it means that it could be so suppressed that it's just not enough that you can measure it in the blood. Or it could potentially be a false negative. And that's why for some of you, you mentioned biopsy or blood. And we'll come back to this for immunotherapy. We tend to try to use these together because we know even in the tissue that, for instance, a mutation is not present in every part of that cancer. And if you biopsy one place, you might find the T790M. If you biopsy another place, you might not. Finding it in one of the places is enough. Sometimes the blood could be positive even when the tissue is negative, and we call that tumor heterogeneity.
So stepping back just for 1 second, and then I know Michelle just held up a piece of paper with what looked like a lot of questions written down on it. When it comes to immunotherapy being different, which I totally get, what you're saying is there's something about certain people that 2 treatments could fire up the immune system.
Yes.
Potentially.
No, so don't misunderstand.
Yeah, that's what I want to go back to.
This is research.
Yeah.
No one would do this in practice yet. We don't know if this will help the cure rate of cancer. We don't know how long you would have to give it. All I'm saying is after 2 doses, it made a major impact on the cancer. So this is what's now being studied in randomized, what we call phase 3 trials. Mm-hmm. And maybe a couple of years from now, we'll know whether this is worthwhile. The reason not to do it in everybody, of course, is there's a danger, just like with the EGFR TKIs. What if you expose that cancer to your immunotherapy in an early case before surgery, and then the cancer comes back and now it's resistant? In other words, you'll have taken that bullet. I also talk about, you have so many bullets you're going to shoot, you don't want to all shoot them up front, because then you don't have any later. Right. Well, in this case, you might have wasted it. So we don't know yet. Thank you for reminding me. I'm talking about research, not practice.
Sure. Yeah. And when you get into the research part of it, you know that we've got PD-1, PD-L1 as markers, so to speak, for immunotherapy, but there's so many markers we haven't discovered yet. There's more markers out there that we don't know.
Look at what she's doing.
Right.
How to apply
so,
it.
Look at what she's doing.
Yeah. So what I was going to do next
she hasn't even looked at
is talk about the markers. You know, I just talked about the mutations, for example, for what we call oncogene-driven cancers like EGFR and ALK and ROS1. For immunotherapy, right now we have 2 tests, which are probably the most standard. One of these is built in to what we call the label for some of these immunotherapy drugs. You have to test for it. And that's the actual PD-L1. So what they're doing is they're doing a stain of your cancer, and they're looking to see whether you have this blocker, this inhibitor, PD-L1 in your cancer. And it's scored. So 50% is a high level. And for some of these drugs, we know they work quite well when the PD-L1 is high. And when the PD-L1 is very low or absent, they don't work so well. But the studies are all over the board. They're not consistent. And what we have found, and I recently published on, is that PD-L1 is not enough by itself. And there is now another marker called tumor mutational burden, or TMB. And it looks at a very different aspect of this immunotherapy surveillance. When I said that lung cancer was a smart cancer, that meant it has the most mutations of any cancer except melanoma. Melanoma tends to have a few more. Childhood cancers, even breast cancer, prostate cancer, low level of mutations. But for lung cancer, we can actually measure how many mutations there are in the cancer now. And typically, there are hundreds. Not all of these are driving your cancer. In other words, sometimes it's only 1 or 2. But the rest of them are stimulating the immune system, and we call them neoantigens. And that's part of what these checkpoint inhibitors go after. So it's important to be able to measure the TMB. My speculation is that now this will go into the label of some drugs or combinations soon. The FDA is reviewing this right now. We can do it on tissue. And in the past, they had to do something called whole exome sequencing, which is a research tool. It's very tedious, takes weeks to months. We can now do it with like a Foundation Medicine test, which our average turnaround time in lung map is 9 days. That's actually really good. That's actually really good. And I'm sorry, just let me finish with this.
Message received.
The latest is we can now do this in blood. And we just published this for the first time last month. Again, this is in collaboration with Foundation Medicine. So depending on how things pan out, because there is a phase 3 trial now where you don't even use tissue. You just use this blood TMB to say whether you should get immunotherapy or not. If that turns out to be positive, it means we're going to have a new tool in our tool chest. And it's going to be very important to help us pick who should receive immunotherapy. Okay, now we'll take another question.
So Barb has a question, and then we're going to go from Barbara's question straight to the online, because Michelle's got a ton of online questions. Yeah.
Okay, just could you talk about the tumor mutational burden. You know, we just had, he went through the both the tissue and a blood biopsy, and they said that the TMB could not be determined. So.
Was it Foundation Medicine?
Yeah. It was Garden.
Garden.
Well, it was Foundation Medicine for the tissue biopsy, right?
Garden doesn't have tumor mutational burden as part of their assay.
Okay, but for the
they do genomics
for the tissue.
But if you want to be on the cutting edge, your doctor will never know this. So if you want to just go in and kind of say, you know, I was hearing the other day that Garden does have TMB, and it was reported in Nature Medicine last week from a Dr. Kim in gastric cancer, and it was highly, highly predictive. So Garden is working on a TMB test as well for blood. In gastric cancer, stomach cancer, if their TMB in blood was positive, there was an 80% response rate. And if it was negative, the response rate was less than 10%. That's the very first report of this. I don't know for sure how it's going to pan out, but what I'm saying is Foundation Medicine, I worked with them. Guardant, I worked with them. CellMax, I worked with them. Liquid Genomics, I work with them. I work with all these people. I'm promiscuous. So the thing is, they're all working to make these tests better.
Yeah.
And, you know, they're competitors. It's like, you know, Chevrolet and Ford, right? So they're trying to figure out how they can offer the best information to the patients. But right now, Guardant doesn't have a commercial test for TMB. Foundation Medicine has it in tissue. We just reported it in blood, but it's still not on the market for blood. So right now, to my knowledge, you can't get TMB from blood.
We had tissue with Foundation Medicine.
Oh, okay. In that case, it may just not have been good enough quality tissue.
Yeah, yeah.
And again, for all of these tests, you know, there's a lot of factors that go into, can you analyze it? The good news is that these companies will just say, we can't give you an answer. In other words, they're not going to take poor tissue, which could be poor for many reasons, and try to give you an answer. They'll just say, we can't analyze it. They have a lot of quality assurance built in.
And we can do future living rooms and have somebody here from Foundation Medicine. We've done that before, but it's time to do it again because a lot's happened. Same with Guardant. Guardant's 2 miles from here. I don't know if you all know that, but they're homegrown right here in the Bay Area. So we can do that as well. Michelle?
Okay. So first, I'm supposed to tell you Ildi says hi.
Who?
Ildi.
Okay.
She's on Facebook.
Hello.
I have so many questions.
Well, just pick an easy one. I don't want any hard questions.
So, people with EGFR receiving Keynote 189 triplet of Keytruda, Lipton, Carbo. Your thoughts?
Okay. So this is a very complex question.
Can you repeat it? Yeah, I didn't hear Michelle.
Well, let me see if you have a cancer with an EGFR mutation in it, how should we view the new data on immunotherapy and chemotherapy? In other words, is that good for an EGFR mutated lung cancer? So, and I know a lot of you, this is very pertinent too. So this particular trial was adding immunotherapy. In this case, it is pembrolizumab, one of the others, to a platinum chemotherapy as the first-line treatment. And it was very positive. In other words, the combination was better than chemotherapy. After this was published in the New England Journal and presented at our annual ASCO meeting, and I was interviewed about it, because a lot of people had opinions about, oh, we should give this to everybody. What I said was, depending on your opinion, this either made things much more simple or it made them much more complex. And what I meant by that is you could interpret this that everybody with lung cancer should get this sort of combination of chemotherapy and a checkpoint inhibitor. On the other hand, all the details of this study, which would take me till tomorrow morning to go through adequately, mean that there are probably some patients that benefited greatly. There are some patients that benefited a little bit from the combination compared to chemo alone. And there are other patients that probably had no benefit. That study didn't have TMB. So some of the studies we have both PD-L1 and TMB. They were incorporated in the study. Some of them we only have PD-L1. And when something comes out funky in the study, where everybody's arguing, what does this mean? What does this mean? It doesn't make sense compared to the other study. It's likely because we don't have all the info. Now, I'm not saying that TMB is the end all, but it clearly adds something to the PD-L1. Now, back to the EGFR. So far, these drugs, either by themselves or in combination with chemotherapy, have not shown a beneficial effect for EGFR mutated cancer. And in fact, in some of the trials, it's been the reverse. And what I mean by that is chemotherapy was more effective than the immunotherapy. But there's hope. So at our ASCO meeting, and again in the New England Journal, the New England Journal is like scooped up all these publications. There was one regimen, it's called Empower 150, which takes chemotherapy plus one of the inhibitors, atezolizumab, plus the anti-angiogenic drug, bevacizumab, I will throw out, also known as Avastin. And when you gave 4 drugs, not only did it benefit the great majority of patients with primarily adenocarcinoma, but it also benefited those with EGFR mutation or ALK. And the data were particularly strong for EGFR mutation. They had more of those. Now, does that mean that you would give this instead of an EGFR TKI? No. But what it means for me is there probably is something about the checkpoint inhibitor with the anti-angiogenic. We already know from other studies that that's promising. That made it beneficial for EGFR mutated. So if I had a patient who had failed EGFR TKIs, whether they start with erlotinib and then get osimertinib, these are the generic names, or somehow they get to the point where they were ordinarily going to get chemotherapy, I would probably do this instead, this Empower 150 regimen, if you can get it reimbursed from insurance.
Right.
It's under review by the FDA right now. I think it will probably be approved, in which case then it should be available. But right now, it and several other studies, we haven't even talked about the IO combinations. In other words, 2 immunotherapies together, like nivolumab and ipilimumab. All of those are pending FDA actions right now.
So do you think the chemotherapy is boosting the IO drug?
There are 100 theories.
Right.
So, you know, one thing that you could speculate is that chemotherapy and radiation therapy damage DNA. When you tumor DNA. When you damage the tumor DNA, it gets released. And remember, these mutated cells are releasing neoantigens, the term that I mentioned earlier. That could stimulate the immune system and allow these drugs that block PD-L1 to be more effective. And at first it was said, well, that's not going to happen overnight. That might take months. And it turns out, if you look at laboratory models, it can happen pretty quick. So that is one theory.
Yeah, yeah.
So we talked a little bit about this sort of triplet where there's a chemo drug, an IO drug, and anti-angiogenic
Yeah,
drug.
so that's 4 drugs.
Yeah. Okay. Can you explain? So I think most people know what chemotherapy is. Most people know kind of what the IO stuff is. But can you explain a little bit about what Avastin?
Right.
What is that targeting?
So how many of you have heard of Avastin or bevacizumab? Can you raise your hand? So a fair number of people. So believe it or not, bevacizumab has now been around probably 20 years. Like anything else, it was the first of the anti-angiogenic drugs. There are now more than one, some pills, some IV, that, again, don't kill tumor cells directly. But in this case, they change the vasculature around the cancer in a way that either allows chemotherapy to work better, or in some kinds of cancer that allow a drug like that to be effective even by itself. In lung cancer, bevacizumab, Avastin, basically is not effective by itself. But in combination with chemotherapy, and again, there are a whole lot of theories on why this happens, it makes chemotherapy more effective. When these drugs first came out 20 years ago, or when this drug came out, many people thought it was going to cure all cancer. we wouldn't need surgery in the future, we wouldn't need anything else. It turns out now that in some kinds of cancer, its role has increased over the years. In lung cancer, its role has decreased. And part of that is we now have all these other new therapies. In other words, we have pills, TKIs, for the oncogene-driven cancers, including ones we haven't even talked about, like BRAF and MET and so forth. And we have immunotherapy. So if I was the person, or if I was the company that made bevacizumab, I would say, well, how do I get in on the new kinds of treatments? So what do? You put it together with an EGFR agent. That's being done, looks really promising. You put it together with immunotherapy. That's what I just talked about.
Yeah.
So it may come back.
Yep. Yep.
Avastin was used historically as a maintenance type drug, right? For folks
Well, it was
without
used
a target prior to
both
IO.
with the chemotherapy and as maintenance.
Yeah.
And in ovarian cancer, again, it's very prominent now, and the maintenance has a big mode of action.
And is one of the thought processes is behind, to put it in like super raw sort of terms, but your like cancer or tumors sort of feed off blood supplies, and if you cut off that blood supply, they have nothing to feed off of and they die. Okay.
How many of you have seen the movie The African Queen?
Oh my gosh, yes.
So I rewatched it the other night.
People.
For those that don't remember The African Queen, Humphrey Bogart, Katharine Hepburn, they're going down this river and they're trying to get to this big lake. And toward the end, the river breaks up into these 1,000 little inlets, and they can't get it through, and they're out pushing the boat, and they get leeches. It's all a bad scene. But the point of it is that is like tumor vasculature. Most people, when they think about it, they think tumors need blood vessels, so you create all these super blood vessels. In reality, the blood vessels, so-called neo-antigenic blood vessels, tumor blood vessels, are crummy blood vessels. They're leaky and they're tortuous, and they don't do a very good job. And part of what a drug like bevacizumab actually does is straighten them out and make them not leaky, and therefore chemo can get in better. It's one of the theories.
It's in the New England Journal of Medicine. It makes them not leaky.
Yeah.
In case you haven't heard, that's exactly how they put it when you read it there. Michelle, do you have another question?
Yeah.
You have a lot of questions.
Okay.
Yeah, loud.
So, can immunotherapy work with brain mets from small cell?
That's another great question. We haven't talked about brain metastasis. I know some of you have experienced that. And so there are a couple of things. First, before we get to the immunotherapy, we now know that some of the new TKIs for both EGFR and ALK, drugs like osimertinib, alectinib, you can find out what the brand names are later, that these drugs penetrate into the brain better than the old drugs. So in the United States in particular, these new drugs have been preferentially used as the first treatment in many cases because, number one, if that patient has a brain metastasis or more, these drugs can shrink them without the need for radiation. And we see this all the time. So just for your information, our radiation oncologists at UC Davis, if they see a new patient with an EGFR mutated lung cancer with brain metastases, and they're not life-threatening, they will defer on giving radiation, and we just give a new TKI that gets in really well. It turns out that immunotherapy we thought wouldn't work in the brain. It does, and it works really well. So already a big study was presented at ASCO this year showing that the T cells can get into the brain, they can attack the tumor. So if you're able to treat a cancer that is a good candidate for immunotherapy, it can shrink brain metastases. Bevacizumab, the anti-angiogenic, can also be effective in some cases with brain metastasis. It's commonly used in brain cancer, in other words, glioblastoma, primary cancer of the brain. So all of these things are benefits because when I see patients, and my apologies to radiation oncologists, but when I see a new patient with lung cancer, usually the first thing they say is, I'm not going to have my brain irradiated, am I? Now, more and more, we don't have to do that. So, all of you that needed radiation in your brain, I'm not saying it was the wrong thing to do, but what I'm saying is going forward, I think we have better drugs so that we can spare patients radiation. If they need it later, 2 years later, again, then you've got it because you haven't used it.
And a lot of what you're saying is managing the cancer, right? And by managing the treatments.
That's right.
You know, yeah.
It's the last question. Michelle, do you have another question you want to go to? And then I'm going to ask the room.
In simple terms, what's the difference between IO and targeted therapy?
Oh.
Okay, well, I addressed this a little bit. So the targeted therapy means that you have a drug against an abnormality in that cancer, usually a mutation, but it could be something else like what we call amplification, too many of the genes. And that TKI blocks that pathway and keeps that cancer from using that pathway to grow and metastasize. So these are typically thought of as what we call oncogenes, two kinds of mutations. One, the oncogene makes the tumor grow faster. The other kind of mutation, tumor suppressor gene, stops it from growing. Cancers can have abnormalities in both of these. So if you have a mutation in your cancer, it's like you've got your accelerator stuck on the floor. This is another analogy.
Like it.
And so the cancer is growing. If you have loss of the tumor suppressor gene, that's like you've lost your brakes. And so it doesn't stop the cancer from growing. And a lot of cancers have the oncogene and the loss of the tumor suppressor. So it's like your accelerator is stuck on the floor and you have no brakes.
What do you do, Dr. Gandara, when the therapy you're on is either or successfully working on your primary tumor and not controlling your metastases, or vice versa?
Right.
They're working on the metastases but not the primary.
It's complicated. And that's why, do you guys know about IBM Watson? Do you know about Watson? Okay, so Watson is artificial intelligence that for many kinds of medicine, especially cancer, are being proposed to basically take over clinical decision-making from oncologists. In other words, Watson's going to analyze your case and tell you what the best treatment is. And it's kind of been a flop.
Yeah.
And in reality, Watson makes lots of mistakes.
Yeah.
So far, it's not like chess.
Right.
In other words, it's not like a chess game.
Right.
But what I'm saying is clinical judgment, I don't think is going to get replaced. In a lot of these cases, there are literally hundreds of factors that oncologist would be thinking of in terms of when do you switch therapy, when do you keep the patient on the same therapy, when do you use something like SBRT, the radiation for an oligometastasis, and you can't dumb this down.
Right.
Like a lot of people try to do.
Right.
And say, oh, we have a new breakthrough. Everybody should continue on the TKI and just get radiation. There was a theory of that. And some people from a couple of cities on the East Coast proposed for many years that someone should never come off of an EGR TKI. They should be on it till they die. And that it was wrong to take them off. And we now have a phase 3 trial that shows actually it was detrimental to keep people on. Should have switched them to chemotherapy. I can't tell you how many cases I've seen where somebody comes in to me and they say, my cancer, my doctor says it's progressing and I'm on erlotinib, otherwise known as the T drug. And they said, I can't come off. And I say, you need to come off. Your cancer is getting worse. Your cancer is resistant to this medicine. You need a new medicine.
We briefly touched on this. So we did a regional living room out in Columbus, Ohio with one of your colleagues, Dr. Carbone. And we talked a little bit about, and you brought it up, so that's why I'm going to raise the question. Can you explain the difference between oligometastasis and oligoprogression?
I'm the one who coined the term oligoprogression.
I might know that, so maybe I want you to be the one to explain it.
So oligo means a few. And what this means is someone could have a cancer that is treated with whatever the treatment is, and then after so many months, the cancer gets worse, but it only gets worse with a couple of new spots. In other words, not widespread. That would qualify as oligoprogression. And so one of the theories there is, depending on that patient's history, how they're doing, are they clinically well, or are they having terrible pain from these areas, you could keep them on the original TKI and just radiate. Or sometimes somebody had, I think, an adrenalectomy, even take out the oligometastasis. So, and that's a valid theory. The problem is that it's kind of like cancer, it's metastasized. In other words, to the point where now they say, oh, well, it's only 10 new spots. We can radiate all of those. Well, you know, that's systemic progression.
Whack-a-mole is only whack-a-mole.
Yep.
As much as it can be, right? Yeah.
They need a new systemic treatment.
Yeah, yeah. Does that make sense to everybody? Just grab your mic and please ask your question.
Okay. Since we learned about his fluids in the lungs and that he has cancer in the lungs, in the fluids, we've been asking the doctors if it can be cured, and they kept saying it cannot be cured for now. They said that after his treatment with the immunotherapy, he will be under maintenance almost forever. And so my question is, why is it so hard to cure the fluid cancer in the lungs?
Right. So I think here our organization, IASLC, has been very important. For most types of cancer, you have a diagnosis and then you have staging. So staging means how far has the cancer spread. For most of these, various investigators try to cobble together the information and they revise the staging system to make it more accurate. In lung cancer, for the last 15 years, it is our organization, the ISLC, who has paid for a group of people to get together and get hundreds of thousands of cases to improve the staging. The reason we want to improve the staging is the treatment for stage 3 versus stage 4, oligometastasis, systemic metastasis, it's all quite different. In this particular situation that you're describing, 15 years ago, a positive pleural effusion, in other words, cells in the fluid, was considered stage 3. During our staging analysis, we actually found out that if you have positive cells in the fluid, it behaves much more similar to stage 4. And so it has moved now into stage 4, but a subset of stage 4. What that means in your case then is the treatment needs to be systemic. In other words, not local. In other words, they can't irradiate the whole pleura satisfactorily.
Yes.
They can't take out the pleura in a way that would cure the disease. So your oncologists are being accurate in telling you that this now is acting in a systemic fashion. It needs something, some kind of treatment would get throughout your body.
And so would you like further explanation on the pleura and where the fluid actually is and how to potentially manage effusion?
Right.
Yeah.
So I don't know, how much fluid, how many cells. There are a lot of details. Remember when I said you can't oversimplify, every case is different. But if there is a huge amount of fluid, then after doing what's called a thoracentesis, where some of the fluid's taken out for diagnosis, a catheter can be put in, a Pleurex catheter. And the patient manages it. Actually, one of my relatives has a Pleurex catheter in right now. And that is a way to remove the fluid and take the pressure off your lung. So that may not be appropriate in your case, but what I'm saying is there are all sorts of tricks. There's also something called pleurodesis, which means they drain the fluid and then they put in something that kind of glues the lung to the pleura and keeps the fluid from reaccumulating.
They have mentioned.
It's like baby powder that makes glue.
Yeah.
Yeah, I don't want to use the term talc because that has a bad connotation
that's
these
not
days.
good. That's not
Yeah.
good.
Sounds nicer.
That's not good.
Yeah. Yeah. Questions? Yeah. I'll come back to you, Bart.
So I'm curious that we have a diagnosis and we have the staging. And do we have a way of telling the patient that how long you have had this cancer? Basically based on the size of it,
right?
Based on the type of it after the biopsy, maybe other factor like the age and all the factor that we can think of to put it in. Can we create a formula to say how long ago roughly that you have started this cancer thing?
Before Dr. Gandara answers, I just want to say I appreciate this question so much because we get it all the time. How long have I had it and how did I get it? Those are the two the biggest questions ever. So
Right.
I appreciate the question.
So it's very hard to know how long someone has had a cancer because some cancers grow fast, others grow slowly. Every cancer started from a single cell. Just thinking about how long it would take for that cancer to be big enough to be diagnosed from an X-ray, from a scan, or to cause symptoms, it's typically years. Now, that being said, the only people who can accurately predict how long it's been there are lawyers because they do this all the time when they sue doctors. They have these formulas for doubling time, which have been disproven over and over. But what I'm saying is that it's very hard to know. And then the second question about why did I get it? You know, in some cases, it's really clear. In other words, we've been talking about mutations that are in cancers. Those are what are called somatic mutations. What that means is it's not in your normal DNA. It's only in the cancer. But some patients have germline mutations. That means it's in your normal DNA and it's been there since you were born. And those tend to be inherited, but sometimes they can be spontaneous. But that would explain familial cancers. So the most probably publicized of these are the BRCA gene, which is in ovarian cancer, some breast cancers, occasionally in lung cancer. I've had several patients with both germline and somatic mutations of BRCA with lung cancer. But those we know why the patient got it. And sometimes it's other syndromes that are associated with a predisposition to cancer, but in many cases, we don't know. And there are a lot of other things going on here. For instance, the EGFR mutated lung cancer is 4 times as common in East Asians as it is in Caucasians. So there's something, again, about probably not the diet, but probably the genetics of East Asians that predispose them to that kind of cancer.
David, are you looking at other cancers that are similar to lung? You said melanoma is highly mutated like lung is. We're finding HER2 and things like that in lung, and that's very well known in breast. Are we looking at, possibly repurposing some of these therapies from other cancers?
And as a matter of fact, I wrote an editorial on this last month. Do you know about this?
What a coinky-dink.
It's about squamous cell lung cancer, and it's
a couple of squames,
It's called in search of an oncogene driver. And what that means is that all of the genes we've been talking about, EGFR, ALK, ROS1, they're primarily in adenocarcinoma. But now we've found that some of these occur in squamous in high enough numbers that it's worth testing. And it's HER2, and HER3, and HER4. And then EGFR, which you all know about, the other name for EGFR is HER1. So this family of mutations, if you added them all up in one of the recent trials for afatinib, it was 21% had one of these mutations, and they did particularly well on that drug. And they did much better on that drug than they did on erlotinib, because afatinib is what's called a pan-HER inhibitor. It knocks off all of these HERs, where erlotinib is really good, but it's only against HER1.
Okay, interesting.
So I know Barb has a question, Peter has a question. I think Barb is next, then Peter, and then what I would like you to talk about is why next-gen sequencing or comprehensive
Right, we should come
genomic
back to that.
sequencing is an important thing. So I would like to get to Barb, and then Peter, and then
We have
Wayne,
21
and then I'll come
minutes.
back, and we got it. Boom.
Okay, I want to go back to pleural effusion, because I thought I understood Edward saying, and correct me if I'm wrong, that he'd had a PET scan and it didn't show that it was clean. And then he had the pleural effusion checked and it was there. If there's cancer cells in the pleural effusion, should they be showing up on a PET scan?
Sometimes not, because they get diluted out. In other words, in the fluid.
Yeah.
Okay.
Thanks, Barb. Peter?
I have
then
a
Wayne.
question. Of course, there's a lot of talk about combination therapies. I'm on Tagrisso, and would it be a good idea to say to my oncologist, should we maybe look at doing a combination therapy now with Tagrisso, or shall I just write it out? And then the related question to that is, I've seen other cancer patients that were on Tagrisso, it failed, they stayed on Tagrisso, and then they added another drug to it.
Yeah.
And to me, that logic doesn't make sense, because if it's not working, why add something to it? So if you can answer both, I appreciate it.
Right, these are great questions. One thing I should emphasize, when I mentioned before that the cancers, EGFR mutated lung cancers, don't do well with immunotherapy typically, there have been several attempts to add immunotherapy, checkpoint inhibitors, to EGFR TKIs, ALK TKIs, and by and large, they have been disasters. And in fact, there have also been increased deaths because of inflammatory reactions in the lungs, things like that. So right now, outside of a clinical trial, there would be no reason to try to add something to Tagrisso or osimertinib, unless it's really on a trial. So there's no data to suggest that chemotherapy plus osimertinib is better than osimertinib alone. There's no data right now to suggest that adding another TKI. But I chaired what's called a project team for the National Cancer Institute, where we developed 3 trials trying to make Tagrisso, osimertinib, a better drug. And one of those is with a TKI. One of those is with what's called an EGFR monoclonal antibody called necitumumab. So we have that trial at UC Davis. We wrote it. It's also at Dana-Farber in Boston, and I think MD Anderson and a few other places. That gets to your last question. What we've found is that patients who are on osimertinib and then have progressive disease, in quite a few of them, if you just add the EGFR monoclonal antibody, which is an IV, necitumumab, there is a tremendous response.
Interesting.
So somehow, the monoclonal antibody is blocking that EGFR in a way that resensitizes the cancer to Tagrisso, osimertinib. Now, this is a clinical trial, and we would not recommend that anybody do this outside of a trial. The reason I say this is a few months ago, I saw a patient in that situation. We said, we have the trial, here's the information, go home, talk it over with your oncologist. And then the patient calls us back a week later and said, oh, the doctor thought that was such a great idea, he already started it.
Oy.
No monitoring for any side effects. Patient had horrendous reaction, emergency room, hospitalization.
Yeah.
So a lot of the things that we talk about that are research, they're research for a good reason.
Yeah.
In other words, we need to find out who should get them, how should we monitor them, and just because somebody's doing something in a clinical trial doesn't mean that someone else should run out and start doing this in their practice. And it's just a word of caution.
And it's very, I'm sorry, it's very important that you know there are no two patients alike. You know, just because you hear that another patient in this room or on the phone or anywhere else in the world is on a certain therapy and they have the same mutation doesn't mean that that's the right therapy for you. You know, and you do need to seek out a physician like Dr. Gandara that, you know, is going to know all of this.
Can I get on my soapbox?
Absolutely,
Okay.
please do.
So I try to avoid politics.
Yeah.
How many of you know about our president's right to try law? Actually, very few of you do.
Yeah.
I stopped listening to her.
It is the law of the land now.
Yeah, it's terrible.
That a cancer patient, if there's a drug that has even gone through phase 1. Phase 1 means you don't even know how effective it is.
Right.
All we know is the toxicity of the side effects.
Right.
That you have the right to try it. It's a disastrous law.
Terrible.
And in fact, there is a drug, this was promoted. How many of you are on Twitter? If you're on Twitter, raise your hand.
How many of you follow David
Dr.
Gandara on
Gandara's a
Twitter?
very big Twitter guy, so if you don't follow him, please do.
There's a drug that they put out a press release last week. They were really proud, and they said, we finished phase 1, and we're really excited. It's highly promising. No responses, severe toxicity, and they said, and now it's in President Trump's right to try. So if you want to try it, contact us.
I want to give him a drug.
Yeah, I think.
I don't mean to, you know, to say that patients shouldn't be involved in these decisions and so forth, but we have trials. We have 800 trials across the United States just in immunotherapy for lung cancer. 800. You know, there are trials right and left. So if you do it in a trial, it's supervised, and you know that you're going to be as safe as possible.
So without sounding like I'm a Trump fan and trying to stay really bipartisan here, what I think, and with Dr. Gandara's.
Well, I'm sorry, I'm not bipartisan.
No, me either.
I said trying. I was trying to be politically correct, and we are in California. There's people from all over the red states watching.
Well, I hope they're listening in.
Yeah. I think one of the challenges, but one of the most important things that Dr. Gandara said is the right to try. I think, or at least I would like to believe there was good intent behind it for patients who wouldn't otherwise have access, right? But with Dr. Gandara's point being there are trials all around this country and around the world where patients can have, hopefully, gain access. Even if it's not in your backyard, I just want to make this point. There are groups out there, Lazarus Foundation in partnership with us to help you get access to these clinical trials if it's something, a road that you're choosing to go down. And I highly, highly, highly recommend at some point in everybody's journey, whether it's an aside to current treatments or whatever, participating in clinical trials.
So this is like on a talk show.
Sorry,
where the guest has said something bad, so Danielle's trying to cover it up.
No, that is not.
Really?
I did not say you say something bad. I did not say anything bad.
So
what I was trying to say.
I love it.
I just want to just like reemphasize that it's like because I'm not a fan of Trump, so I'm just going to say it out there like I'm not, but I'm not going to get into it.
I think we better strike this from
I hope James edits it in. But what I'm trying to say is in talking with people, like seriously around country, access is an issue, and that's a whole other living room.
Let me
I'd like you to come
finish.
back for.
Yeah.
The right way to get a drug that's not on the market
Clinical
is
trial.
either a clinical trial or compassionate use program.
Thank you.
So in other words, this phase 1 agent that I mentioned, which just has only been used in 10 patients in the world, right? Now they want to offer it to everybody. Compassionate use means that the drug has been through enough testing that we know its side effects, and we also know that it has some activity. So every one of these drugs we've talked about, immunotherapy, osimertinib, erlotinib back in its day, et cetera, all of these were available on compassionate use programs. And in fact, Bonnie was just telling me how somebody got access to a drug in Europe through a compassionate use program right away. But it's one that we knew was worthwhile for the patient to take, rather than some, flim-flam drug, which is probably never going to amount to anything.
Exactly. And when you're watching TV and you see, some of these direct-to-market commercials, don't get all excited and think that this is the miracle drug for you. We're all different. You have to have a relationship with your physician where you can go in and, talk about these things.
The moral of the story is that willy-nilly, ill-informed use of these drugs is a really bad idea.
Right.
So, right? I mean, at the end of the day, to put it like right here, to Dr. Gandara's point, whether it's through clinical trials or compassionate use, that's what I meant from the very beginning.
That's okay.
If I came across otherwise,
I have one last thing on this topic. The last thing is, all of you have the best resource in the world to bounce these questions off of, and that's the Adario Lung Cancer Foundation. If you hear about, this drug that sounds like it's the best thing since sliced bread, call them up. Not uncommonly, Bonnie will send me an email, and she'll say, have you heard about this drug? It's called Wonderful Drug.
Right.
Yeah.
And he'll
I'll
go,
say,
oh my God, no, stop right
but,
here.
Or I'll say, it's actually really promising, and there's a trial for it down at City of Hope, or whatever.
Exactly.
And we are only able to give that back to you guys because of the amazing key opinion leaders that we work with, like Dr. Gandara. So with that,
but people throughout the country and the world, really.
Absolutely.
He's not the only one.
I'm close.
He is close. He's like here at the top. Wayne, did we answer your question, or do? Yes, I would like you to answer, and then Ron. I'm sorry, Wayne was before you.
Hi.
I'm keeping track.
What do you see coming down the pipe in terms of modality and treatment outside of combinations of existing drugs? In particular, I'm thinking of like CAR T cells.
On
CAR T cells.
Yeah. So believe it or not, we have a trial for lung cancer at UC Davis. So this is one of those things that probably is, there's more enthusiasm than there's data. In other words, we know that taking out your T cells and incubating them with antigens and then reinfusing them in certain kinds of malignancy like leukemia can be very effective. We also know that there is an entire new class of side effects which have never been seen in man before from this kind of therapy. So it's not a free lunch. The trials that are being done now are saying, can we do this in other cancers? Can we do this in melanoma? Can we do this in lung cancer? And eventually we'll know the answer. So we have one of those early trials. I don't know how effective it's going to be. There's been some question about immunotherapy is so effective in cancers like melanoma and lung cancer. Our CAR T cell therapy, is it going to be better or just different and maybe more toxic? And I should bring up one other thing because we didn't talk about it. And that's the immunotherapy, the checkpoint immunotherapy has a whole host of side effects that oncologists have never seen before. And there is an entire procedure for monitoring your blood to make sure that your liver and your kidneys and everything else are working okay. And this is what we call the itises. In other words, hepatitis, nephritis, encephalitis, cardiomyopathy. So these drugs, because of what they're doing, they can not only rev up your immune system against the cancer, but occasionally your immune system will think something else in your body is foreign and it will attack it. Your lungs, your kidney, your liver, etc. So it's worthwhile mentioning that because your oncologist is getting all of this experience now. Oncologists are learning how to manage these things. Patients also need to be aware of these side effects. Sometimes they're easier to diagnose. We can pick them up with a blood test. Sometimes it's more difficult. And sometimes we don't know for sure what's going on. So the example of the fluid around the lung. A patient that was being managed by another oncologist, but I was seeing the patient periodically for second opinions. The oncologist sent him back and he said, oh, he's got this big effusion now and I think he has progressive disease. And I said, well, did you tap it? Did you do the thoracentesis? And he said, yeah. And I said, did you find cancer cells? And he said, no. He said it was full of T cells. I said, I'll bet this is a side effect of immunotherapy. The patient came down to see us at UC Davis and I presented him to our pulmonary people, our surgeons, and they said, oh, this has got to be recurrent cancer. They just didn't find it. So we did another thoracentesis, no cancer. Dr. Cook at our place did a VATS, went in, looked around, took biopsies, no cancer. This was an immune reaction, and it was treated with steroids, and it got totally better. The guy's in a complete remission. Wow. But what I'm saying is it's a new, totally new phenomenon. So by now, your oncologist knows about all these things because the drugs have been out long enough, and he's used them, your oncologist, he or she, has used them in melanoma and other kinds of cancers, not just lung cancer. But the reason I mention this is that, as Bonnie said, every case is different. And I looked it up in the literature, and I said 4.5% of the people getting this drug get pleural effusions. He turned out to be one of them.
Wow. Yeah.
So I'm going to shamelessly plug ourselves for a second, and then I'm going to go to you, Ron, just because we were on this topic. So our lung cancer registry, which is patient-reported outcomes, the baseline of it looks at you, the patient, where you started, where you've been, where you've come, and hopefully longitudinally watching where you're going. But one of the things in that, to Dr. Gandara's point, and one of the very first studies that we're running through it, is an IO immunotherapy PRO patient-reported outcome study that we're doing with Moffitt in Florida and Jefferson in Pennsylvania, where we're looking to answer some of these questions from the patient's perspective, which is such, we talk all the time about a patient voice, and you guys telling us by not just tell us so we can tell them, right, and show them because it's open sourced and anybody can come back and see what this looks like and how they can then, as physicians and researchers, come back and then help to improve these drugs and thereby improve sort of some of these adverse events or side effects. So that's just a, so if you're on, sorry, I'm gonna finish, sorry. If you're on IO, if you're in the room, if you're watching right now live, and or if you're watching later, please go to lungcancerregistry.org and sign up for the study, because the information that you give us based on your experience alone is invaluable to physicians like Dr. Gandara, so that they can go back and then try to make things better.
Because we can then see, is a certain kind of side effect at what we expected? Is it more? Is it less? How is it being handled?
Yeah,
really important.
Ron has a question. We got like 5 minutes, so I want to.
The beauty of the lung cancer registry is open source, so it's not hidden in some lab somewhere that belongs only to that institution. So I like that. I learned from Dr. Gandara that anything that ends in an MAB is a monoclonal antibody. So it's not just necitumumab, but others like cetuximab and others like
bevacizumab. Avastin is a mAb.
Yeah.
Right. But I wanted to put a plug in listening to this discussion about red states, blue states, that
red states,
if you are a lung cancer patient, it doesn't matter.
Yeah.
What matters is that you participate while you're healthy sick into a clinical trial. These clinical trials that are advancing the state of the art only happen if you get in while you're healthy sick. If you're thinking this is a Hail Mary, last ditch, I'm really sick, I'm going to go for one, they're not going to let you in. They don't want to skew those results yet. And where did I have right to try or not? The compassion sick, we should use that compassion sick care because I think only 50 people use it in a year.
Yeah.
So there's an instrument out there that's safe and monitored, and if you're on a clinical trial, not only you're advancing the care, maybe you've combined that next new drug, but I think the standard of care in a clinical trial where they watch you and make sure that you stay healthy sick is much better than your normal.
So if I can just comment on what Ron just said, how many of you are familiar with the term performance status, which is kind of a funny term? A few, not many. So a performance status means how functional you are as a patient. And when you're seen by a team, the nurses, the doctors will assess how functional they think you are, and there are several parameters you use, like can you do your daily life? Do you still driving your car? Are you still shopping? Are you in bed half the time because you're so weak? You know, and they'll assign a performance status. So for most clinical trials, if you use, there are different kinds of scales for this, but one of them that's used, which is mistakenly called ECOG, it's really Dr. Zubrod, it's the Zubrod scale, goes from 0 to 5. And if you're a 0, that means you're as healthy as anybody else, you have no symptoms. If you're a 5, it means, unfortunately, you're deceased. And then there's everything in between. So if you've got some symptoms, you're a 1. And for a lot of these treatments, what we've found is that if you are a 2 or a 3 or a 4, or at least a 3 or a 4, the treatments don't benefit you. And in fact, all you get is the side effects. That's what Ron is talking about. And that's why if you're really so debilitated that you're in a wheelchair, you can't function, you probably won't get into a clinical trial. And the reason is safety. Now, in some of them, we allow in patients with performance status 2. But the goal is to get patients in a trial earlier so that we're able to give them the treatment with a reasonable expectation they're going to benefit and they're not going to have side effects. Just as an example of this, they did a trial of the immunotherapy in England. And they specifically wanted to look at people with bad performance status. And they were saying, well, maybe this is like Lazarus. Maybe we can give it to people with bad performance status and they'll do actually great. And instead, they did terrible. They had 3 times as many side effects, and the benefit was really minimal. In this same trial, they had elderly patients who were healthy. In other words, 80 years old, but with a good performance status. They did great. And we have trial after trial showing this, that age is not the determinant. It's your performance status.
So we've got housekeeping for those of you who are veterans, and you know we normally have to do it, which I want to get to, so just so we can close out the meeting, and then I want to finish the conversation with some end questions. But for purposes of TV, so for those of you who don't know, Channel 26, Peninsula Television, this will be playing over and over for the next 30 days, this meeting on local cable TV. So if there's anything you think you missed tonight, you don't want to hit the YouTube link, just turn on Channel 26. You're sure to find all of us up here talking about this. But
or you're awake at 3 in the morning and want to see yourself on TV.
Yeah, but I do want
to
say some of my thank yous, and then I want to come. It's kind of weird how we have to do this for time purposes, but I want to come back in. I want to say thank you, obviously, to Dr. Gandara for coming here and speaking to us tonight. So huge round of applause for Dr. Gandara.